This is Betty Rafferty, and this is Breast Tomosynthesis, Current State of the Art. I should let you know that I have a research grant from Hologic for the investigation of breast tomosynthesis, and I consult for Hologic. I have no other financial disclosures to make. So, in summary, mammography works. We know that if women come in promptly for their mammogram, that they have a much lower risk of dying from breast cancer, and that decrease in the mortality rate can be as much as 50%. In fact, nothing has reduced mortality from breast cancer over the years more than mammography. But we also know that mammography is not perfect, and in fact, as many as 20% of breast cancers will be missed on a mammogram. And it's that fact that has prompted people to look for other types of modalities, either to supplement or completely replace mammography. As mammography gets denser, we know that the sensitivity of the exam also decreases, and that's led people to want to address the limitations of mammography even further. In fact, it was that recognition that breast density could have a negative impact on mammography that helped drive the adoption of digital mammography. And of course, this is the iconic paper that was published now 12 years ago, hard to believe, that really drove a transition of mammography from an analog modality to a digital modality. People recognized that with the higher contrast resolution of digital mammography, that they would be able to hopefully see better through the density of the mammogram to see the cancer which was there against the similar appearing background. And for some women, it worked. The interesting thing is that people forget that for the entire cohort as a whole, digital mammography did not perform better than analog mammography. But for some women, specifically women under 50, women who were pre or perimenopausal, and women who had dense breast tissue, digital mammography did perform better than analog mammography and found significantly more cancers. What's interesting when you look at these three subgroups is that they're really all the same women. They're united by the fact that they likely have dense breasts. Women who are under 50 tend to have dense breasts. Women under 50 tend to be pre or perimenopausal, and then certainly women who have dense breasts have dense breasts. But it didn't take long before radiologists recognized that density probably wasn't the entire answer to the quandary about why mammography was imperfect. While it helped to have better contrast resolution from the digital mammogram, it didn't completely solve the problem. In fact, if you step back and think about what is likely limiting the sensitivity of mammography, it's not just the density, but it's the actual physical overlap of structures. The overlap of those structures, the normal components of the breast, can actually obscure cancers from our view. They can also have the opposite effect. Those overlapping structures can actually mimic abnormality when no abnormality is there. We're very familiar with that scenario. When we bring someone back, do some additional pictures and see that in fact the asymmetry that we saw on the mammogram turns out to be nothing, just overlapping structures. So interestingly, we see the same kind of failing. These overlapping structures accounts for both the deficits in sensitivity and specificity of mammography. We're all kind of familiar with this scenario. This is a mammogram, obviously, and we see that there's asymmetry on one side compared with the other. Now, just looking at this image, I can't really tell you any more than that, that the fact that asymmetry exists. When I remove the asymmetry from the surrounding tissues, though, I can easily tell you that this is a spiculated mass and that this is extremely likely to be a cancer. Why can't I tell you that in vivo? Well, because that mass and its margins, which are the key to my understanding what it likely is, are surrounded by other tissues that obscure it and don't let me see it as well and don't allow me to be so accurate. So the elegant thing about tomosynthesis is it addresses that particular failing. It's a three-dimensional mammographic exam whose goal is simple. It's just to minimize the impact of these overlapping structures in the breast. And if that can be accomplished, it should have beneficial impact on both the sensitivity of mammography, allowing us to find more cancers, and the specificity from mammography, allowing us to have fewer false positive callbacks due to those overlapping structures. So how does it work? Well, it has to exist on a digital platform. So breast tomosynthesis wasn't with us until we had digital mammography commercially available. So the breast remains compressed on a digital detector, but then rather than remaining stationary, the X-ray tube is going to move in an arc over the breast, taking multiple low-dose projection images. In this case, 15 low-dose projection images during a 4-second sweep. Those 15 low-dose projection images, the same regardless of the size of the breast or the acquisition angle of the mammogram unit, are then reconstructed into the final three-dimensional data set at 1 millimeter slice intervals. And that will form the tomo that we are going to interpret. So if we think about the ability to remove the impact of overlapping structures, it should offer us particular advantages in our interpretation. We should be able to see lesions more clearly, just the way we could see that cancer once it was removed from the surrounding tissue. It should help us with our margin analysis and understanding the extent of abnormality, because it's not going to be obscured or camouflaged by surrounding tissue. It should allow us to reduce our recall rate by minimizing the impact of summation artifact on our recalls. And then because it's a three-dimensional examination, it should allow us to be able to localize lesions using just the single acquisition. But it's interesting that every modality has its sweet spot, its particular strength that is going to be exploited to make it perform at its best. For analog mammography, that was spatial resolution, incredibly high spatial resolution. For digital mammography, as we talked about, it's contrast resolution. For tomosynthesis, it is margin analysis. That's going to be the key to us really utilizing this modality to its fullest potential. Here we see an MLO digital mammogram, dense breast tissue. I'm going to direct our attention to this particular area here, which is zoomed up for you, and then put it side by side with its tomosynthesis acquisition. So now as I scroll through this data set, looking at this particular area, I can see that in fact, this is a spiculated mass. In fact, the bulk of this cancer is right here. It's just incredibly difficult, if not impossible, to see it as such on the two-dimensional image. But on the tomosynthesis acquisition, I'm able to scroll back and forth and right away perceive the spiculated margins of this mass and invasive ductal carcinoma. Here's another mammogram, MLO views and CC views. My colleague actually called this patient back for a very subtle abnormality seen only on the CC two-dimensional image. Here it is, zoomed up to help you see. Would you have called that back? We all say yes, but who knows? What we're going to look at first is the MLO tomosynthesis acquisition. Remember that the potential abnormality was not seen on the MLO view. So let's have a look here. As I scroll through this data set, I see there is indeed a spiculated mass here superiorly on that MLO view, occult on the two-dimensional mammogram. Now on the CC view, remember that's where the possible abnormality was seen. As I scroll through the data set here, I see not only is there a spiculated mass that my colleague very perceptively saw, but there's also an adjacent mass here. And in fact, this was a multifocal invasive ductal carcinoma. Here again, dense breast tissue, CC, and MLO views. This patient has some calcifications. Difficult to see, although we know that digital mammography does an excellent job at trying to depict calcifications. They show up incredibly well, likely because of that enhanced contrast resolution. As we look here at the CC mammogram on the left and slice from the tomosynthesis acquisition, you can see that there are indeed calcifications, but they're much more easily seen here on the tomosynthesis slice because we've removed the impact of the surrounding structures, making it more easy to see those calcifications against the background. The same on the MLO acquisition here, the two-dimensional image on the left and the three-dimensional image tomosynthesis slice on the right. And this, of course, was ductal carcinoma in situ. Now, when one looks at introducing a new modality into clinical practice, there's a set of rules that you have to go through, a process in the United States. Obviously, that's overseen by the Food and Drug Administration, and the heart of that involves the performance of clinical trials, attempting to show whether the device has specific efficacy or use for a specific indication and whether it's safe for the public. So in order to approach these clinical trials at first, what we did was a reader study where 12 radiologists were given imaging to read in two modes. First, they looked at the digital mammogram, the way we normally would in clinical practice. Then they were given the tomosynthesis acquisition to interpret in conjunction with the two-dimensional mammogram. And their performance in terms of detection of cancer, recalls, etc., was looked at in those two modes. This is an ROC curve which depicts the performance of the 12 readers all pooled together during that clinical trial. And ROC curves are a common way that we do analyses to show whether a particular modality is effective in radiology. Perfect performance on the ROC curve is in the upper left-hand corner where you would recall every cancer, true positive findings, and recall nothing else, false positive findings. So here we see the navy blue line is the reader's performance when they looked at the digital mammogram. Here in the pink line is their performance when they had the digital mammogram plus the tomosynthesis acquisition. So we see the pink line moves up and to the left, showing that more accurate performance, which was highly statistically significant. So that's the kind of information the FDA is looking for. But to me, the most significant piece of this trial was that every single radiologist, each of the 12 readers, statistically significantly improved his or her performance. And that was regardless of the reader's degree of clinical experience. One person was less than a year out of their radiology training, and one person had more than 30 years experience. And regardless of the fact of whether they were a generalist, performing all aspects of radiology in their practice, or whether they were a specialist in breast imaging. When you see that kind of improved performance, regardless of the background of the reader, it's much more likely attributable to the modality than the reader that you picked. Now, how did tomosynthesis do for specific features? Well, as it turns out, it's difficult to separate out specific features further than saying that they involve calcifications or non-calcified features. As we spoke about earlier, digital mammography does a fantastic job in looking at calcifications. In fact, when we first switched to digital mammography, it seemed to do almost too good of a job. We were calling back women, seeing more calcifications, and having a hard time discerning whether they were there on the prior analog films. That all worked itself out as we became more and more digital and had digital priors to compare to. So we didn't expect that tomosynthesis would do a really different job in looking at calcifications because digital mammography was already so sensitive for them. Here you can see the data broken out by calcifications versus non-calcified lesions. And again, the blue represents the radiologist's performance looking at just the digital mammogram, the pink when they also had the tomosynthesis acquisition. It improved somewhat, going more up and to the left, but it was not statistically significant. Does that mean that tomosynthesis is not useful for calcifications? Well, it is, but not quite in that sense. Here on the left, we have a digital mammographic image, and you might be able to make out that there are some calcifications here in this image. Hard to say any more than that. You would bring her back, do magnification views, as we always have done, to try and get better morphologic information about those calcifications. But if we look at the tomosynthesis imaging, true, we do see more calcifications than we did perhaps on this two-dimensional image, but what we also see is the spiculated mass associated with those calcifications. So the beauty of tomosynthesis for calcifications in part lies in the fact that it might unmask an associated finding like this spiculated mass, like architectural distortion, that makes us more likely to appreciate that this is a malignancy and more likely to call that patient back correctly. Now, where tomosynthesis shines is everything that's not a calcification. So masses, architectural distortion, asymmetries. Here you can see the pink line representing the radiologist's performance when they utilize tomosynthesis going way up into the left, a huge gain in their accuracy and performance, which was highly statistically significant. Here, this is a cropped image of a young woman, 32, who came in with a lump. Looking just at this feature, you might say, gosh, is this going to turn out to be something? Hard to tell. You could see this perhaps effacing with a spot compression paddle, or would it turn out to be something? Would you only know when you went to ultrasound? Tough to say. But if we look at the correlate tomosynthesis image, we can certainly see that this is a spiculated mass. This is a cancer. Why can't we tell it so easily here in the two-dimensional image? Because its margins are obscured by the surrounding tissues. Here, it's sitting in fat, and we can easily appreciate that this is going to be a malignancy. But the fact that those surrounding tissues camouflage the mass make it more difficult for us to see and more difficult for us to be accurate regarding what it is. How about those false positives that we mentioned earlier as well? We view those or think about those largely as the recall rate from screening mammography that turns out to not be a cancer. So using tomosynthesis in that same clinical trial, we saw that radiologists were able to reduce their recall rate by 37% when they used tomosynthesis. Again, because tomosynthesis minimized the impact of summation artifact on that two-dimensional mammogram. Now, many people said, you will never realize this type of improvement in performance in true clinical life. This is just a clinical trial. And I agreed with that. You know, clinical trials are enriched. They're not actual patients. You might perform a little bit differently. You might be more cautious in true clinical practice. So when tomosynthesis did become clinically adopted, I was surprised to see that some practices saw an even greater reduction in their recall rate than 37%, some as many as 50%. And then you come to realize that the amount that you can expect your recall rate to be reduced is at least in part dependent on where it starts out to begin with. When you have a recall rate of 25% to begin with, you can expect that you're going to be able to reduce your recall rate much more substantially than someone who starts out with a recall rate of 6 or 7%. How do you do this recall rate reduction? Well, in a similar way, we look at this two-dimensional mammogram and we see that there's an asymmetry here in the subareolar region. And recall that the breast kind of cones down toward the nipple. The compression of the breast is limited by the chest wall at that point. And yet 20% of cancers occur in that subareolar region. So you've got to be careful here because the compression is never optimal right behind the nipple. So I think that calling this person back was, very smart. When we look at the tomosynthesis images, though, what we can see is we scroll through our data stack and we're able to move back and forth and identify individual structures, those unique structures that are actually summating to give you the impression of a potential mass on that two-dimensional image. Here we see 3 different slices from the tomosynthesis imaging, And we can see the individual structures that are widely separated in space that summate to give you this appearance on the two-dimensional mammogram. And that's how you can feel assured that you're not overlooking some sort of a mass or something else, particularly when you're familiar with the appearance of malignancy on tomosynthesis. Now, in that particular reader study, every single one of the 12 readers significantly reduced his or her recall rate. So again, being able to impact both on the sensitivity and the specificity limitations of two-dimensional mammography. Now, our first opportunity to see how tomosynthesis would do in a real-world clinical situation came from Per Skane and his group in Oslo, Norway. Dr. Skane is the director of the National Screening Program in Norway, and he made a commitment to trying to see whether tomosynthesis could afford his patients additional benefit. He didn't have the FDA as a hurdle to cross, and he was able to implement the tomosynthesis clinically earlier than we were in the United States. But he committed to the implementation in a very interesting way. He wanted every patient's acquisition of the two-dimensional and three-dimensional study to be reviewed in 4 separate ways. What he did is a single radiologist read just the digital mammogram alone. A different radiologist read the digital mammogram plus the tomosynthesis imaging. A third radiologist read the digital mammogram plus CAD to see whether that would have a similar performance to digital mammography plus tomo. And then a fourth radiologist read a synthesized version of the two-dimensional image that we'll talk about a little bit later in conjunction with the tomosynthesis imaging. This particular paper dealt with comparing the reader looking at the digital mammogram alone to the reader comparing the digital mammogram plus the tomosynthesis, exactly what we were just talking about in the clinical trial. What he found was that cancer detection went up by 27%, and false positives, recalls from screening that turned out to not be cancer, went down 15%. And that was from a baseline of having a very low recall rate to begin with. Interestingly, almost every additional cancer that they found through the use of the tomosynthesis turned out to be an invasive cancer. His invasive cancer detection rate increased by 40%. And if we step back, that makes sense because we know that DCIS on a mammogram generally presents as calcifications. We talked about the fact that calcifications are well depicted on the two-dimensional image and that tomosynthesis does not add a lot to that. So the things that tomosynthesis is finding, the masses, distorted architecture, asymmetries, those are going to turn out to be, by and large, invasive cancers. And those are the ones clearly that we would prefer to find, as those are the ones that have lethal potential for the woman. Now, in the United States, breast tomosynthesis was approved for clinical use early in the year of 2011. And so our first opportunity to see how it performed in the United States in a true clinical environment came from Steve Rose and his group in Houston. And what they found was they were able to significantly reduce their recall rate from a very respectable 8.7% to 5.5%, a 37% reduction in that recall rate. They also significantly increased the positive predictive value of a recall, more than doubling it. That's the likelihood that someone you recall from screening will turn out to have a cancer. They increased their cancer detection rate by 35%, and almost all of the additional cancers that they found using the tomosynthesis were invasive cancers as well, similar to the results seen from Dr. Skane. The increase in the cancer detection rate from 4 to 5.4 per thousand, the 35% increase, did not turn out to be statistically significant, likely because the number wasn't big enough to be able to produce statistical significance. The study didn't have enough power. And as we looked at that result, we realized that it was going to take lots and lots and lots of examinations and to be able to make a statement regarding true impact on the cancer detection rate or the sensitivity of mammography. And so that's really the genesis behind a number of groups getting together, 13 different groups, to pool their data to be able to look at the performance of tomosynthesis in a true working clinical environment. This paper was published in JAMA about 2.5 years ago, and it represented the work of 13 different sites, both community and academic sites, having radiologists who were specialized in breast imaging and those who performed general radiology as their practice. And so it really represented a truer cross-section of American imaging practice. And what we found was that cancer detection amongst the entire group went up almost 30%. And the false positive recall rate simultaneously went down 15%. Again, being able to impact on both of these areas of deficiency in two-dimensional mammography because they both relate to the overlap of normal structures. The positive predictive value for a recall, the likely that a recall is going to produce a diagnosis of cancer, went up almost 50%, and the positive predictive value of a biopsy, the likelihood that a biopsy would diagnose a cancer, also went up 21%. Said another way, the number of benign biopsies went down when tomosynthesis was utilized. It was really everything that you could have hoped for in an imaging modality. Again, almost all of the additional cancers detected in the group of women undergoing tomosynthesis, almost 500,000 exams, were invasive cancers. There was a relative increase in the invasive cancer detection rate of 41%. In fact, the detection of DCIS remained stable before to after the addition of tomosynthesis. This becomes important when we talk about the potential for a modality resulting in overdiagnosis and overtreatment. The bulk of discussion around overdiagnosis and overtreatment in breast cancer revolves around DCIS. There certainly are some critics who would say that we shouldn't treat invasive cancers, that we diagnose either, that they may not go on to ever kill the host. But I think most people feel that treating invasive cancers is still an important thing and confine most of their concern regarding diagnosis and overtreatment to ductal carcinoma in situ. So the fact that virtually every additional cancer that tomosynthesis enabled the radiologist to find was an invasive cancer was an important finding. Now, when we think about tomosynthesis, of course, we can say we're talking now about doing the two traditional acquisitions, the CC and MLO views, particularly in the screening setting. But that's not a given. If we step back and think about it, if we're talking about tomosynthesis as a three-dimensional type of examination, if we're able to get all of the imageable breast tissue on the detector in, for example, the MLO view, and we have this three-dimensional component to understand lesion localization, why do we need the CC view? That makes total sense. And it would be beneficial if we didn't need the CC view because we would have less radiation, less compression, less time for the patient, fewer images to interpret for the radiologist. That would be a real winner. But in order to figure out whether we really need the two-dimensional acquisition to have maximal benefit, we did another reader study. And in this reader study, 15 different radiologists were given imaging to read in 3 modes. First, they had the two-dimensional digital mammogram. Then they were given just the MLO tomosynthesis acquisition to read in conjunction with the digital mammogram. And then finally, they were given the CC tomosynthesis acquisition so that now they had the Two-View Tomosynthesis acquisition plus the digital mammogram. And the radiologist performance was recorded at each of those 3 modality cutoffs. Here we see another ROC curve, the dashed white line representing the radiologist's performance when they looked at two-dimensional standard digital mammography, the yellow dashed line representing when they added two-view tomosynthesis. Now, I just said this was a study to look at the performance of one-view tomosynthesis, but The interesting thing about the radiologist performance using two-view tomosynthesis versus standard digital mammography was that the ROC curve looked incredibly familiar. And when we overlaid it from the earlier reader study using 12 different radiologists, this is what we saw. Virtually identical performance between 15 new people to the 12 prior readers, again confirming that it's likely the modality making the difference here and not the reader. But how did those readers do when they used only the single MLO tomosynthesis acquisition? Well, they did better, as you can see here in the turquoise dashed line, and it was statistically significant, but it was only about half as well as they did when they had the two-view tomosynthesis to read in conjunction with the digital mammogram. So one-view tomosynthesis, significantly better than digital mammography alone, but two-view tomosynthesis, significantly better than one-view tomosynthesis. And again, seeing that result makes you step back and ask yourself why. But when you start to look at real clinical cases, knowing that this is the result of this investigation, it becomes clear to you why that is. It's because if cancers all grew as a sphere, then they would all be equally visible from any angle. But they don't grow as a sphere. Many cancers are irregular. They have kind of a plaque-like component growing out along existing planes, particularly invasive lobular cancers. And those are going to be more visible in one acquisition than another. And that acquisition may not be constant. It may be CC sometimes. It may be MLO others. And so knowing the result of this investigation, which has been corroborated now in clinical practice, and knowing how cancers grow, it's easy to see why two-view tomosynthesis would be optimal. And I think that we'll always have to rely on two-view tomosynthesis to get the maximal performance from the modality. Now, the FDA approved breast tomosynthesis for both screening and diagnostic indications. The true value of the modality, though, one could argue, is going to be in screening, where you have the opportunity to find cancers that would be occult on the two-dimensional image in the asymptomatic woman, and where you have the opportunity to call fewer people back from screening. That's going to be the maximal bang for your buck. Now, in terms of thinking about screening patients with tomosynthesis, it's just a reality that most practices would not be able to implement this modality in one fell swoop. It would be a stepwise process of converting over from their existing digital mammography units to units capable of performing tomosynthesis. So many people would be practicing, as I did for many years, in a hybrid environment where you have both standard digital mammography machines and those that can perform tomosynthesis. Given that, how do you decide who should get screened using the tomosynthesis machine? Well, there's no right answer here. You can kind of take any approach you feel works for your patients and your practice. You could go that the patient's going to get the first available modality. If the next machine that's available is two-dimensional, she gets that. If the next machine available is tomosynthesis, she gets that. Entirely reasonable way to go. And in fact, that is what we did in our practice early on, mostly because we wanted to not have a selection bias in looking at the results when you use tomosynthesis for screening. We wanted to see, was it good for all women rather than presupposing the women it would be best for. Having said that, one would surmise that the higher the woman's breast density, the more valuable the tomosynthesis would be and the better it would perform. It might be better for women who are younger, and it might be most valuable to use them for women of increased risk, where there's going to be more cancer to find in that particular population. All of these are legitimate approaches, and many practices have chosen to triage patients specifically to getting the tomosynthesis based on one or a combination of these factors. That's all fine. Whatever works for your practice is completely acceptable. Now, when we think about breast density and tomosynthesis, as I said, one would assume that these concepts of density and structure overlap are somehow linked, if not immediately translatable. And it's true that when we use tomosynthesis in dense breasts, the gain under that curve in the ROC analysis is almost 3 times higher than it is in fatty breasts. So if we go back now to our clinical trial studies and break out that data by density, we can see here that for women who have non-dense breasts, the gains using tomosynthesis are smaller. Having said that, the tomosynthesis was still significantly better, significantly more accurate than when radiologists used digital mammography alone. If we look at the performance in dense breasts, we can see all the curves shift down and to the right because mammography is not as sensitive at baseline in dense breasted women. And they also shift apart more, showing the increased incremental gain that you get from using tomosynthesis in this population. Here we see a cropped image from a two-dimensional mammogram here on the left. And I can tell you, I've looked at this image so many times and I would never see this abnormality on this two-dimensional image. I can just honestly say that. But when you look at the tomosynthesis correlate here, it's clear that there's architectural distortion here. There's an invasive ductal carcinoma. This is it. It's just that you could never pick this out of the two-dimensional image because the margins of that architectural distortion are obscured by the surrounding tissue. Once you look at these side-by-side pictures, it's immediately obvious, not just to radiologists, but to the lay public, how this modality works. How about the non-dense breast? Here we have fatty breasts, CC views, and MLO views. And here I'm honed in on a spot on that CC two-dimensional mammogram on the left. There's kind of a smudge here. Is this something? Is it just a little bit of normal parenchyma? Hard to say. Would I key in on it? I don't know. But on the tomosynthesis image, you can see that it has spiculated margins. This is a 3-millimeter invasive ductal carcinoma in this fatty breast that you're able to more accurately diagnose because you can see its margins. The smallest amount of structure noise can really degrade your ability to optimally interpret that two-dimensional image. So if we think about the clinical practice using tomosynthesis, and we go back to that cohort of about 500,000 examinations that I spoke about earlier, and we now divide that out by breast density, we can get a sense of how much more accurate tomosynthesis might be for women with dense breast tissue. The interesting thing is that the addition of tomosynthesis significantly improved cancer detection rates and significantly reduced recall rates for women with both dense and non-dense breasts. For women with non-dense or fatty breasts, there was a 30% increase in the invasive cancer detection rate with a simultaneous reduction in recall rate of 13%. Really, really impressive. Of course, for women with dense breast tissue, the gains were even more. Almost a 50% increase in invasive cancer detection when using tomosynthesis with a simultaneous reduction in recall rate of 14%. This is huge, the opportunity to diagnose 50% more invasive cancers in women who have dense breast tissue. That's what really lies at the adoption of this modality. Now, of course, we've been talking about using the two-dimensional and three-dimensional images together. That's how this was approved by the FDA in 2011. So when you're talking about that kind of an acquisition, you've got to be cognizant of the dose. And in fact, when approaching this tomosynthesis project, if you will, the entire machine, the modality itself had to be reconstructed in order to deliver a harder X-ray beam, different generator, different tube filter combinations, in order to keep that combined acquisition under the FDA MQSA dose limit of 3 milligray. So here you can see the ACR phantom data here, looking at the combined image on the right, which comes in at about 2.7 milligray, compared to both the two-dimensional mammogram alone on that unit and the type of dose exposure that you'll get if you just did the MLO acquisition in addition to the two-dimensional mammogram in the middle of the histogram here. But of course, patients don't understand milligray, and many radiologists don't understand milligray either. It doesn't have any kind of real-world context for them. So in order to explain to patients a little bit more clearly what type of dose we're talking about from this study, this is a histogram looking at effective dose. The third bar over in this histogram shows the average annual background radiation dose in the United States at sea level, just from living. So things like cosmic rays, radon from the ground, things like that. And it's about 3 millisieverts. Here, the fourth bar over in this histogram shows the average annual background radiation exposure in Denver, Colorado. Denver is, of course, at a higher altitude, more exposure to cosmic radiation, and you can see that it's at about 4 millisieverts a year, just from living. Now, if we look at the combination examination, 2D plus 3D, both exposures, both breaths, that's the same effective dose as the difference between living in Boston at sea level and in Denver 1 mile above sea level. And when explained in that way and put in context, when you appreciate the potential benefits of the examination, almost all patients want to have this. We've performed mammography safely now for so many years, maintaining the MQSA dose limits as specified. And I think that the opportunity to find breast cancers earlier should not be negated by this, really what I think is a negligible increase in the dose. Having said that, is dose reduction not important? Of course it is. We all subscribe to the ALARA principle as radiologists. And so right away, we began to think, how could we reduce the dose from tomosynthesis? Well, one strategy for reducing the dose is, of course, to perform only the MLO acquisition. We talked about that. By eliminating the CC tomosynthesis acquisition, you could reduce the dose. And we looked at that here. In this histogram, I've also included the average dose of a digital mammogram in the United States, here now seen as the yellow bar of the histogram. And you can get data like this from the FDA periodically. We know that we all have to submit our accreditation data to the FDA every year. And so they compile it and are able to give us things like this, the average dose of a digital mammogram in the United States. Of course, the MLO only acquisition on top of the two-dimensional mammogram would result in an increased dose, but certainly less than that of the combined two-view tomosynthesis acquisition on top of the two-dimensional mammogram. But we just talked about the fact that doing only that MLO acquisition is only half as accurate as doing the two-view tomosynthesis acquisition, and was statistically significantly not as effective. So in order to get the maximal accuracy, the maximal benefit from the tomosynthesis, you need to perform both tomosynthesis acquisitions. So in order to now reduce the dose, there's really only one place to go, and that's to think about eliminating the standard two-dimensional mammogram. Now, some people thought, well, you don't need a two-dimensional mammogram at all. I have to say, I was not personally in that camp. I thought the two-dimensional mammogram was important. For me, it serves as an opportunity to look side to side on the current examination to appreciate any asymmetry. It helps you compare with the patient's prior examinations, and it also serves as an overview or a roadmap, if you will, for understanding distributional findings in the breast, like segmental calcifications, for example. And so I thought that it was important to keep the two-dimensional image somehow. But the question was, did you have to take that two-dimensional image at the cost of further radiation to the patient, or could you somehow make a two-dimensional image from the three-dimensional acquisition you had just done? And so this was really kind of the genesis of thoughts about this synthesized mammogram, which would be made from the tomosynthesis reconstruction. The way that it works is the patient has a standard tomosynthesis scan acquiring those 15 low-dose projection images. Those images are then reconstructed at 1 millimeter slice intervals into the tomosynthesis slices that we interpret as the tomo, but then those individual tomosynthesis slices undergo another analysis using a separate algorithm to generate a synthesized two-dimensional image. Now here on the left, a standard digital mammogram. On the right, a synthesized digital mammogram from the patient's tomosynthesis reconstructed data set. And in this iteration of the synthesized mammogram, it's also trying to enhance a couple of items, particularly small, high attenuation foci, like calcifications, and here you can see some calcifications here are more easily visible on this synthesized mammogram. And it's also attempting to emphasize radially oriented lines, which may be associated, for example, with architectural distortion. But you can see that the synthesized mammogram, while looking slightly different, is very, very close to the standard mammogram and very useful in trying to set an overview for your interpretation of the tomosynthesis data set. And so now, if we think about just doing the two-view tomosynthesis acquisition and then generating a synthesized mammogram, we can see that that dosing is going to come in at a little bit less than the average standard digital mammogram in the United States, a really effective dose reduction. Of course, this synthesized mammogram is only good if it works, and so our first opportunity to look at the synthesized mammogram in clinical practice came from Dr. Skana again, because if you recall, when we talked about Dr. Skana's vision of implementing the interpretation of tomosynthesis, one of the arms that he had set out was going to be this synthesized mammogram in conjunction with the tomosynthesis data set, and you could compare it against the tomosynthesis acquisition with the standard digitally acquired digital mammogram. And that's exactly what this paper did. So he had about 25,000 women who presented for screening. He used two different iterations, two versions of the synthesized mammogram, each for about a year. What he found was that the earlier version of the synthesized mammogram was not quite as good as the true two-dimensional mammogram, finding slightly fewer cancers and also calling back slightly fewer women, but that's not what we're about. We're all about cancer detection. But using the updated version of the synthesized mammogram, cancer detection and false positive recall rates were virtually identical to the standard two-dimensional mammogram plus the tomo, and you can see that data here, showing that indeed the synthesized mammogram was ready for prime time. But remember, that synthesized mammogram is part of the tomosynthesis data set. It's derived from the tomosynthesis data set, and it's meant to be interpreted in conjunction with the tomosynthesis data set, not to stand alone on its own. Why do I mention this? Because as we'll talk about in a second, it takes longer to read these studies when you have the tomosynthesis. And so people are constantly looking for shortcuts, ways to cut down on that reading time. And one of the ways that has been proposed by different groups is that you look at that synthesized mammogram first, and if it's normal, you don't look at the tomosynthesis data set, and you just move on. This is one particular presentation that advocated that in this particular study from the San Antonio Breast Cancer Symposium of a couple of years ago. It's a study from the UK, and in this study, they looked at the synthesized images first. And if those were normal, then they didn't look at the tomosynthesis data set. What they found was there were 11 patients in whom the synthesized mammogram was judged normal or benign, but looking at the tomosynthesis data set showed a suspicious finding. And 2 of those 11 turned out to be cancers. So this is a cancer detection rate here of about 0.8 per thousand. You're giving up about a half to 2/3 of the tomosynthesis performance if you don't look at the tomosynthesis data set, but only rely on the synthesized mammogram. That is not the way the FDA intended that imaging study to be used, and I would say not the way that you should use it in clinical practice. You will miss small, subtle cancers. It's just a fact. They will have that summation artifact added back in, if you will, on the synthesized mammogram. There's no free lunch. You have to look at all the data set. Would you ever just look at the MIP of an MRI and never look at the source data? I guess you could, but you would get burned. And so the summary of this particular investigation suggested that this might be an effective way of reducing time spent reading and be cost effective, but they did acknowledge that a larger trial in the screening setting was required. I would say forget it. Once you look at enough of these studies, you'll recognize that those small, subtle findings are hard enough sometimes to see on the tomosynthesis imaging without trying to find them on now a derived two-dimensional image. Here's a two-dimensional image showing some calcifications. They're a little bit faint here, particularly on the PowerPoint medium. Here on the synthesized mammogram, you can see them more clearly. Remember, I told you that the synthesized mammogram attempts to emphasize those small, high attenuation foci like calcifications, but the true tomosynthesis slice shows you not only the calcifications, but the irregular spiculated mass that they are associated with, the best interpretation of the patient's true situation. A couple of additional considerations. I touched on this briefly. Interpretation time. Obviously, there are more images to look at. How much longer will it take you to read them? Well, in order to look at that, one of our former fellows did a study where she took 10 radiologists and gave them imaging to read, either just two-dimensional or two-dimensional plus tomosynthesis for periods of 1 hour, and she recorded how many exams they could read over several different sessions. And what she found was out of the 10 radiologists, 1 person actually read the tomosynthesis imaging a little bit more quickly, but that was certainly not the norm. 9 of 10 radiologists took longer to read the tomosynthesis acquisitions. And on average, they took about 30 to 50% longer. The key is not how many those radiologists could read, but the fact that they really were in this kind of 30 to 50% bubble, if you will. So if you know how many exams you're going to do on your tomosynthesis unit, and you know how long it takes you to read those exams, then you can increase that by a factor of 50% to read the same number of studies. And using that kind of back-of-the-napkin calculation, you'll be able to tell exactly what kind of a time impact that's going to have on your practice. Now, the kind of saving grace or the silver lining to this cloud is that diagnostic examinations tend to go much more quickly because you don't have to do a whole host of additional views. Often you can just go to ultrasound, for example, to be able to complete your diagnostic evaluation once you have the tomosynthesis imaging. So diagnostic exams are more quickly accomplished, and you're able to kind of shift some of that radiologist power to the increased resource needed for the screening interpretation. And many people have found that that has worked well for them in their practices. Reimbursement, well, of course, this is a moving object, but as we sit here and speak today, this is the current payment that's now allotted in additional to the digital mammogram from CMS for the tomosynthesis. And I said that in addition to the digital mammogram. Will this stay? Of course, nothing ever stays. We know that Washington is an ever-changing landscape, and I'm sure that this will also evolve in the future. Having said that, this at least acknowledges that the equipment costs money, and it is additional radiologist time and expertise to perform the interpretation. And so just a couple of thoughts on the future of tomosynthesis. How about computer-aided detection? Well, right from the outset of tomosynthesis being a clinical modality, different groups were interested in trying to implement CAD in conjunction with the tomosynthesis, maybe to help speed up the interpretation, for example. But I don't know about you. I didn't really have a lot of stomach for the thought of seeing a bunch of these little marks on those individual slices. But the CAD has gotten FDA approval to use on the synthesized mammogram and is still, at least as of today, available to use in conjunction with a standard two-dimensional mammogram. Whether it will always have reimbursement, you can make your own guesses, but it's there certainly as an aid if you find that useful to you. How about the opportunity for reduced compression? We know that compression is useful because it generates structure spread on a mammogram, allowing us to see around and behind different structures. Well, tomosynthesis does that too by minimizing the impact of structure noise. The interesting thing is that you absolutely still need compression for tomosynthesis to function optimally. In part because you need the breast to not move. Motion is the enemy of this study because it markedly degrades the margins of those lesions. And remember, margin analysis is the sweet spot of this modality. So while I think there might be opportunity for reduced compression, I think we'll never fully eliminate compression. And remember, if we don't compress the breast as much, we have to radiate it more in order to penetrate it properly for a mammographic exposure. Again, there's no free lunch. How about contrast-enhanced tomo? This usually comes up when people say, how about tomo versus MRI? Well, they're fundamentally different types of studies. Tomosynthesis and mammography in general being an anatomic study, whereas MRI is a physiologic study. But could you give contrast and then do a tomosynthesis acquisition? You certainly could. And there's been a resurgence of interest in doing contrast-enhanced mammography in general. So coupling the exquisite detail of these lesions with physiologic information is very interesting. But I'll leave you with this particular slide from Tabar, who has contributed so much to our understanding of the benefit of mammography to the population as a whole and has looked at this longitudinally in many different ways. He kind of presents this histogram, which looks almost like a dose-response curve. When you implement mammography, you expect to see this type of a reduction in breast cancer mortality. And I think that a lot of physicians can relate to this type of presentation in terms of the actual quantifiable benefit of screening in a general population. It's my hope that as the years go on and tomosynthesis is implemented more and more, we find cancers earlier when they're more treatable, that we might be able to further impact on breast cancer mortality. And so I wish you luck and fun in utilizing tomosynthesis. And with that, I'll thank you for your attention.